Hi! This time we head to Mexico to hear and watch a talented young dentist, Dr. Jack Goldberg. Dr. Jack Goldberg received his DDS degree from the Unitec University of Mexico City. He then received a certificate in advanced prosthodontics, as well as a Master of Science from the University of Southern California in Los Angeles. Additionally, he still obtained a fellowship in implant dentistry from the University of Louisville in Kentucky. Dr. Goldberg works in private practice in Mexico City and is a member of several organizations. He has authored numerous scientific publications and research papers in the fields of implant prosthodontics and aesthetic dentistry. He lectures worldwide on topics of interdisciplinary treatment planning, implant surgery, restorative and aesthetic dentistry. My friend Jack Goldberg will present diagnosis and implant treatment indications for the edentulous maxilla. I'm sure this is a lecture interesting for everyone connected to implant rehabilitation and general aesthetic dentistry. See you soon.
Hello, everybody. My name is Jack Goldberg, and I have the privilege of being one of the lecturers for this second edition of the International Aesthetic Masters Online Congress 2017. First of all, I would like to start my presentation by thanking Joao and Rui for giving me the opportunity of participating in this international and groundbreaking event. As most of you probably already know, I'm originally from Mexico City and I practice in Mexico City as well. So today we're going to be talking about a fascinating topic for me: diagnosis and implant treatment indications for the edentulous maxilla. I find this topic to be fascinating because of its complexity. We know that it has a lot of layers of different complications and a lot of layers of different possibilities. So that gives us the opportunity to understand and analyze different aspects of the edentulous maxilla. I would like to acknowledge my education. I did my dental school in Mexico City. Then I was able to get my prosthodontic certificate from the University of Southern California, as well as a master's in orofacial pain neuromedicine. And then I got the ITI scholarship for an implant surgical training at the University of Louisville. Then after 4 years of being in the United States, I decided to go back home to Mexico City and had the privilege to partner with Dr. Ricardo Mitrani, which most of you already know. He's one of the most established and well-known prosthodontists in Mexico and internationally as well. So I came back to Mexico around 2 years ago. This is our main office in Mexico City. And being able to combine the experience, the knowledge of Ricardo and my energy and youth and new training, we're able to create a synergy. And this is very important because we're doing this online congress to be able to share the knowledge, to share the experiences amongst our international colleagues. So this is something that we take very seriously here in our group in Mexico, and sharing is the most important aspect of our everyday treatment. We take teamwork very seriously as well, and this is why we've been able to get together around 40 people right now that are working together in our group. Grupo Dental Bosques is the name of our group and our clinics in Mexico. We have around 5 clinics right now. And one of the main concepts, as I said before, is being able to share and live experiences. So I want to start the lecture with this quote by Steve Jobs that says, "Life is about creating and living experiences that are worth sharing." So it's not only about creating and living these experiences, the true satisfaction comes when you share these experiences so others can live through our experiences, but most importantly, live through our mistakes as well. So we're going to be talking a lot about errors and what to do and what not to do in these type of cases. So we've all seen cases like this coming in our practices, right? We have cases in which we have terminal dentition cases due to decay or periodontal conditions. We have failing dentitions due to trauma, or we have edentulous arches that already come into our offices without teeth. So the main question in all these cases is where to start. And we think that this is one of the most important questions we need to ask ourselves. Where to start, right? Because there's a lot of different techniques out there. There's a lot of different schools of thought on how to approach these cases. But where to start and how to start is one of the most important things that we're going to be talking about during this presentation. So the $1,000,000 question out there always is the number of implants, right? I remember one of the first questions that I always asked my professors was, how many implants do you need to treat a maxilla? How many implants is the correct number? Because we get a lot of information from many different places, from research papers, from companies, from colleagues, from friends who said, oh, you can do this with 4 implants, you need to do this with 6 implants, or you need to do this with 10 implants. And we get a lot of different information. So what's the right answer? And we see all these cases here on the screen in which got these images, panoramic radiographs from the internet. And we can see that our colleagues there decided to use a lot of implants to restore these cases. So to some of us, this might look a little bit excessive, and to some of us might look normal. So what about restoring an edentulous maxilla? Can we do this with 4 implants? The answer is yes. We have a lot of literature supporting this type of reconstruction on 4 implants with great long-term results. But what about using 6 implants? Again, we have a lot of information with 6 implants that support this type of therapy. And using 8 implants, is that something that is something we need to consider in this world nowadays, or is something that is more from the past? And again, most of the long-term data we have on edentulous maxilla is with traditional treatment planning with 8 or even 10 implants. So all of these options are right and they're correct. So now the answer is how to choose one or the other. So for example, let's take this case into consideration in which we have through 12 steps how we take a patient from a terminal dentition, that means a failing dentition in most of the maxillary teeth, and how do we take them step by step, enable the end to provide them with an implant supported reconstruction on the maxilla. And we're going to go into detail with this case, but what about when you have both the maxilla and the mandible? That adds another layer of complexity, because then we are talking of a bimaxillary case, and that adds a little bit of complexity to the case. And again, these cases are something that if we go through the right data collection steps and the right treatment planning steps, this is something that we can do in our office every day. So with all these questions in our minds, we decided to come up with a simple, straightforward, and easy visual aid to try to understand these type of cases. So we came up with this classification. We call it the LTR. This is a project that I started with Dr. Adrian Paulini. He was my co-resident at University of Louisville, and then Dr. Ricardo Mitrani mentored us through this project, and also Dean Morton helped around in the project. So we're able to come up with this classification that, again, we call the LTR. the L stands for lip, the T stands for tooth, and the R stands for ridge. As I said at the beginning, treating the edentulous maxilla is one of the most difficult and complex treatment therapies in our profession. So we try to make it easy to understand, but nonetheless, it's very difficult to get all the information in one paper or in one classification. So I urge all of you to really dive into the concept of trying to understand the depth of the complexity of these type of treatments. So what's important with a tooth? We know from literature from Dr. Frank Spear and Dr. Kokich that the main point or the starting point of any maxillary reconstruction should be the position of the central incisor. So this is where we start. So we start with the position of the central incisor. We right now don't care where the lip is or where the ridge is. We want to position the tooth where aesthetically is going to fit in the patient's face. So we position the tooth. We know again from the literature that a central incisor's average length is around 10 to 11 millimeters, and we're going to position that average size tooth, and then we're going to use it as a starting point, and then we're going to go from there. We're going to position it with a correct angulation as well, and then we factor in the lip. So the lip has three very important areas that we need to consider. The length, which again we know from the literature, it ranges from 18 to 22 millimeters, and it depends a little bit on if it's men or women and the age of the patient. But also the thickness. If we look at it from a sagittal view, the thickness of the lip is very important. And one of the most important aspects that we take into consideration every time we treat our patients is how dynamic is this lip. That means how much it travels when the patient smiles. And then at the end, we're going to take into consideration the ridge. So once we have the tooth in the right position and we understand the lip dynamics, we're going to factor in where the ridge is. And then we're going to analyze to see if we have enough bone to place the implant or we need to go through augmentation procedures for implant placement. So once we have all of that information, we're going to analyze the lip now in a clinical scenarios to make it a little bit more understandable for the audience. So lip dimensions, again, as I said, we go from a large lip to a medium or a small lip, and we can see the difference here, for example, in how much gingiva is displayed when the patient smiles, right? So also something very important to take into consideration. We know that as the patient ages, so the older our patient is, they're gonna lose some of that muscular tone in the area of the lip, and the lip is gonna start appearing a little bit longer and with less mobility. So in this slide, for example, we can see three different patients, and we have a large lip, a medium lip, and a small lip. And again, of course, we have a small lip or a lip that's very dynamic. The patient is going to show the full length of the central incisor, for example. And some of the times, the patient even is going to show some of that gingival display, and we call it a gingival smile, or there's many names out there, but it's something we need to take into consideration if we're treating a terminal dentition case. Something that we use a lot and then has been explained very nicely by Dr. Christian Coachman and his group when using the DSD is utilizing video to analyze the dynamics of the lip. Because when we come in and we ask our patients smile and we bring this huge camera with soft boxes and we tell them give us a natural smile, it's very difficult for them to actually smile naturally. So when we have a video, we can make them laugh, we can tell them a joke, and then we're gonna actually get the full smile of that patient. So here is just an example of a patient that we're trying in denture teeth for a case you're gonna see a little bit later during the presentation. So video is something that is very useful in our everyday practice, and it doesn't have to be something very expensive. You can use your smartphone. Most of the smartphones today have very good cameras, so that should be more than enough to analyze these lip dynamics. And why is this so important? Because, for example, we have this patient in which, as I said before, the lip is very dynamic. That means the lip travels a lot when the patient smiles, and we have that gingival exposure at maximal smile. So, for example, if we were going to treat this patient, this is a healthy patient, of course, but if we were going to treat this patient for extraction and implant placement, this is something critical, very, very important that we need to take into consideration when treatment planning. Because if we don't do this, we're going to end up having that junction of the prosthesis and the ridge shown when the patient is smiling, and that gives a very unaesthetic result. So what about the tooth? We know we have different tooth shapes. We talked a little bit about dimensions, and in 1 hour there's not a lot of time to talk about everything, but everything is well explained on the article. But we know there's different tooth shapes: square, ovoid, and triangular shapes. And for example, in this case that we're trying in denture teeth for a fixed detachable prosthesis on a patient, originally we decided to go with a more ovoid shape for this patient, but the patient didn't like it. So we ended up changing the tooth shape for a more squarish shape in which the patient was much more happy. And at the end, we take into consideration the ridge. And as I said before, we have different types of patients, and the presenting anatomy of the patient is the most important factor. That means if the patient comes into our office that has been wearing a denture for 40 years, we know that the denture is going to end up having a little bit more resorption on the maxillary ridge. And it's going to be very different than if we get a patient with a failing dentition due to decay, for example. The patient is going to have most probably very good bone structure in the maxillary ridge, but the teeth are failing. So we need to take that into consideration when deciding which type of classification that patient is going to end up being. And we have from class 1 to class 4. So class 1 is what we call a no defect class. That means that the tooth size is going to emerge directly from the ridge and is going to give a patient a very aesthetic result because we don't have to use any type of pink colored material like we need to do in class 2. So class 1 most probably is going to be a terminal dentition case in which a patient's dentition is failing due to decay. So we have very good bone structure. Now class 2, we have a vertical defect. That means that the patient has lost some vertical length and vertical resorption. And if we want to have a good average size tooth with good proportion, most probably we're going to end up having some pink. And that pink color material could be composite, could be porcelain, or it can be acrylic. So for a class 2 patient, it could range from 1 millimeter of pink to 10 millimeters of pink. And that's very important to know, because class 1 and class 2 patients are going to be restored with a fixed type of restoration, as you can see in the diagram. And then that brings us to class 3. Class 3 is a horizontal defect. So these type of cases most of the time are cases that are denture wearers, in which due to the use of the denture we get both vertical and horizontal resorption. So if we try to treat a class 3 patient as a class 2, we're going to end up bringing the teeth forward a lot, and we're going to end up having a foot trap there, and we're going to go into detail a little bit more down the road. Why? Because the patient needs lip support. And as you can see in the diagram, we have very good lip support with the flange of the denture. So that is telling us that it's going to be a removable type of prosthesis. And then a class 4 is a combined defect, in which we have a horizontal defect and a vertical defect, and that's going to be restored as well with an overdenture, which is going to have a labial extension or a flange. And this classification was published at an international journal of periodontics and restorative dentistry, so you can look it up online, and we go through step by step of everything that I explained briefly now. So let's go into the clinical cases. So a class 1 patient, as I said, the tooth is gonna emerge straight from the ridge. So for example, here we have three cases which we restored here in our group, and we have cases that have been restored with metal ceramics, cases that have been restored with zirconia ceramics, and we're gonna go into detail as well when to go from one material selection to the other. So for example, this patient came into our office and he was complaining about not being comfortable with his smile and not being secure with his smile. That means he was not very comfortable aesthetically, but he was not very comfortable with function as well. And we utilize the concept that is being very well described by Spirit Education, in which we go through the EFSB, which means the aesthetics, the function, the structure, and the biology. So we need to analyze our patients in these four categories, which are very, very important. So when we go a little bit more into detail with our patient here, we can see that the patient has some recurrent decay. He's being restored for all of his maxillary teeth. He has recurrent decay. He has chipping of his restorations. He has some patching of the restorations which were done before coming into our office. And when we have our occlusal shots, we're going to focus mostly in the maxilla for this case because is the topic of the presentation. So we can see that the patient has recurrent decay. So first thing obviously we need to do is take some radiographs and see what we're dealing with. So we can see that the patient has multiple root canals in his teeth. He has post. He's been previously restored. We can see some recurrent decay around the restorations, and we go into the medical history of the patient. So the patient was telling us that he has had some medical problems lately. He has been taking a lot of new medications, and those medications are creating a xerostomach effect. That means that the patient has less saliva in his mouth, and that's going to increase the rate of the decay. And that's very important when dealing with older patients. So first thing we tell our patients is we really don't know what we're dealing with until we remove all the restorations. So we create what's called a shell provisional, which is going to be relined in the patient's mouth. We remove all previous restorations, clean the decay, and we're going to reline this shell provisional, try to give him a little bit more aesthetic contours, and the patient leaves the office with a conformative provisional based on what he had before. So aesthetically, it's something very similar, but now it's one piece, it's solid, it's well adapted to the margins of the teeth, so the patient is feeling much more comfortable. Then once we have that, we're going to duplicate that provisional into a clear acrylic template, and we're going to use it as a surgical guide eventually, but most of all, we're going to use it as a radiographic guide. So we ask our patient to take a CBCT, and we're going to put it in the software, analyze it, and see which places are the best to place the implants, which sites are the best regarding bone. And as I said before, we have some areas that are already edentulous, and we have some areas that we're going to remove or extract some of these teeth, but we can see that we have very good apical bone to the apex of the teeth, so we decided to go with a technique that is called sequential extractions. So we have two options in these type of cases. Either you remove all the teeth that need to be removed, place the implants either immediately or in a delayed phase, and then you can restore them. But in this example, we decide to keep some of these teeth. So we strategically decide which teeth to keep, and we're going to use them as abutments to hold the provisional restoration. So we have all the analysis from a three-dimensional standpoint, and then we go into the surgery. So we extract some teeth, we place the implants, and we keep some of these teeth again to hold our provisional, which eventually the anterior teeth are going to be extracted as well due to the depth of the decay. So once we have that, we have a very good stable provisional, so there's no need to utilize the technique in which we immediately load these implants. And we're going to show other cases in which we do, but in cases we have teeth that we can keep, we decide to go with conventional osseointegration protocols. So once we give it a good 3 months for these implants to integrate, we bring the patient back and we're going to use a 3D scan. Here we have 3 members of our group. which are scanning the patient using a 3-shape equipment. And using all the scan bodies, we're gonna scan the patient with the implant position, and that's gonna give us a 3-dimensional position of the implant, and that's gonna give us as well the ability to design a provisional restoration, which is gonna be designed in the computer and is gonna be milled as well. So this is a CAD/CAM generated implant supported provisional restoration, which is giving us already the contours, the ideal contours that we're gonna use for these patients. So what we're gonna do in this case is we're gonna bring the patient back, we're gonna extract the teeth that need to be extracted, and we already have that implant supported provisional restoration, which is gonna go exactly in place right after we do the extraction. So it's very important from a psychological standpoint. We never have this patient in a removable prosthesis. He's always been wearing a fixed type of restoration, and that is a great advantage for our patients, so they don't have to go through this period of having a removable. So once we have that provisional restoration, we go through a trial period. It's very important that we test this from a phonetic standpoint, from an occlusal standpoint, from a phonetic standpoint, and we want to road test as well how the patient function and parafunctional activities are impacting our provisional restoration. So we give it a good time to heal, to make sure that all these extraction sites are well healed and there's not going to be any recession in those areas. And once we have that, we contour to create these pseudo papillae in those areas. And once we create those papillae, we're gonna go ahead and create what's called a personalized impression post or impression coping, in which we want to try and recreate the position of the implants. So we decided to keep some of the molars because they were very good teeth. So there's no need to remove teeth unless it's absolutely necessary. In this case, we saw that we have very good amount of tooth structure left. So we decided to keep those teeth and take a conventional open tray impression. Once we have that impression, we're gonna create our model work, our master cast, in which we're gonna be working on directly from there. Now, a very good question to ask right now is why not take a final digital impression? So we've been trying to do that in the last couple of years, and the literature explains as well that we're not there yet to take a full arch digital impression on implant that's going to be 100% accurate every time. So we are taking it, but we always want to have a traditional cast on the side to try and make sure that everything is passive. Now, most probably in the next couple of years, we're going to be able to do a full arch implant digital impression predictably, and we're going to be on the lookout for that, but we're very close. So here we're going to be using a digital design in which everything is designed in the computer. And once we have the final design, which is done by our lab, then we're going to sit down with them, analyze it, make sure we have good support for the porcelain, and we decided to do a one-piece milled metal restoration that is going to be layered with porcelain. So here we have the layering process of our prosthesis, and once we have that coming back from our lab, we're going to try it in the patient's mouth, and we're going to see how that looks. So there's still room for metal ceramics nowadays, and I'm going to be talking about different types of cases, different types of materials as well, depending in which area of the world. Some areas don't have access to high-end milling for zirconia, and we're using traditional metal. So I'm going to be talking about a different array of cases and different material selection as well. So depending where you are in the world, you can utilize these concepts as well. Good aesthetic results when using metal, and we can see that everything is well healed in that patient. So we're gonna try it in, make sure that everything is passive. When we're dealing with full arch or a one-piece restoration, we need to make sure that radiographically and clinically, using a one screw test, everything is going to be passive, and we're not going to apply any unnecessary forces to the implant biomechanics. So again, these are the final pictures. We can see how everything integrates very nicely. We can see the patient lower teeth. We're trying to upkeep with his hygiene, with using protocols to remineralize those teeth to try to avoid going for a implant restoration in the mandible. Right now, as I said, patient is going through medical treatment, so we decided to restore the maxilla, and eventually once he's done with his medical treatment, we're gonna go ahead and restore the mandibular teeth as well. So we can see that the patient is very happy. Aesthetically, we're able to bring him from a failing dentition to a combined maxilla with some individual teeth that had crowns on them and a one-piece implant supported prosthesis. Very important to note with this case, we never used a removable restoration or removable prosthesis, which is something very useful and very comfortable for the patient. So that's an example of a class 1. Again, as I said, there's no pink, but that then we move to class 2. So class 2 means we are going to have some pink. And as I said before, here are 3 examples of a class 3 patient. First example is a metal ceramic prosthesis. The second example is a zirconia ceramic prosthesis. And the third example is a metal acrylic prosthesis. So different materials, different number of implants in each case. First case we have 8 implants, second case we have 6 implants, and third case we have 4 implants. So all of these prostheses and restorative designs, they fall into a class 2 category in the LTR classification. So let's start off with this clinical case. This case is a case I treated at USC during the residency with Dr. Winston Chi and Dr. Arman Charbati that were helping me out with this case. So we have a case, comes in, early 80s patient, again, taking medications that were lowering the amount and the quality of the saliva in his mouth. We start seeing some recurrent decay. Patient came in already previously restored 2 times before and asking for a third reconstruction. We can see that on the upper left, patient had a bridge or an FPD, and it failed. It came off because the teeth were fractured due to decay. So we go again into analyzing these cases radiographically, and we can see that this patient has a lot of recurrent decay everywhere, and we sit down with him and we ask him, what do you want from the treatment? So the patient told us, I want something that is going to last for all my life. And we told him there's nothing lasts forever, but if we already are in your third tooth supported reconstruction and we're seeing recurrent decay in almost all of your teeth, we recommend you to move to an implant supported restoration. And he was very happy with the solution, so we decided again to use the same technique as I previously described it. That is a sequential extraction. So we strategically decided to keep 3 teeth in the maxilla and 3 teeth in the mandible. Then we're going to use a same procedure as I explained before, a confirmative provisional. And once we have that confirmative provision, we're going to let everything heal. After 3 months of healing, we're going to start with our aesthetic workflow and see exactly if the patient is going to be a class 1 or a class 2 patient. As I explained before, cases that are failing dentition cases most probably are going to end up being a class 1 or a class 2 because we should have enough bone. Cases that are failing due to a periodontitis and that have a lot of bone loss, a lot of attachment loss, can be converted into a class 3 if necessary, and we're gonna show a case later as well. So we go through again our workflow. We're gonna position the central where it needs to be aesthetically. Once we have that position, we're gonna duplicate it into a clear radiographic guide, and we're gonna take a CBCT scan. We're gonna analyze which sites are the best sites for implant placement, and once we decide where are the sites we need to take into consideration is again which type of prosthesis we're going to use for this patient. So all of this consultation process between the surgeon and the restorative dentist needs to happen before the surgery. So right now we sit down with our surgical team and we decide Do we want to have 4 implants? Do we want to have 6 implants? Do we want to have 8 implants? And the answer ties back to the LTR. So when we look at the LTR, we need to decide if this is going to be a class 2 patient, which we decided already based on our aesthetic workflow. Then we have 3 options for a class 2. We can go metal ceramic, which can be segmented or one piece. We can be zirconia, ceramics, and again, that could be segmented or a one piece. Or we can use metal acrylic. So metal acrylic needs to have more vertical space, vertical restorative space. So that leaves that prosthetic design for this patient out of the equation. So we have metal and zirconia, and we could go segmented or one piece. So once we sit down with our patient, we go through different options, and the patient wants something that is retrievable, wants something that it's easily maintainable, and that we have a very good contingency plan. So that contingency plan means that if something fails, it's going to fail individually and not as a whole segment. So we decided to go with a traditional 8 implants in the maxilla and 8 implants in the mandible, 8 implants in the maxilla and 8 implants in the mandible, which nowadays might seem a little bit excessive. This was done some years ago, but still it's a very good clinical solution that, again, as I said before, has a very long-term data with support to its performance. So we go with the conventional osseointegration protocol. We have a patient in temporary restoration while everything heals, and then we're going to take our master impressions. This is before the era of digital intraoral scanners, so we are using traditional laboratory methods, which is we decided to choose this case again to show to some of our colleagues in some areas of the world that don't have access to digital dentistry yet. These are conventional protocols. So we have some denture teeth. We're going to set up the denture teeth in a rim that's going to be placed on the implants. We're going to try that in our patient's mouth, and we can see that aesthetically we're pretty much where we need to be regarding our aesthetic parameters. The patient is very happy with it, so we decide to move forward with it. Is create a final provisional because again we had the provisional that was on teeth, and now we have implants. So we want to road test those implants, and as I said before, we want to test them phonetically, aesthetically, functionally, and we want to see functional and parafunctional activities on our temporary restoration. So we go through this technique in which we use 2 layers of acrylic, a dentin-based layer and an enamel-based layer to try to recreate and have a more aesthetic result. And as we can see right from the get-go with our temporary, we're going to use some pink composite because the patient needs to have some pink because he is a class 2. So aesthetically, everything looks where it needs to be. Patient is very happy, so the patient is going to go back home, use it for at least a month or 2 months to make sure that everything is perfect. Then the patient comes back, gives us the green light, and as I said before, this is going to be a 3-segment prosthesis, which is going to be a metal ceramic. So when we want to segment the prosthesis in 3 or 4 pieces, we need to have more implants in order to biomechanically be stable. So here we have the laboratory started with the layering process of the prosthesis, and we can see the final result of the laboratory here. Beautiful ceramic work by Domenico Cascioni, and final result: 3 pieces segmented on 8 implants in the maxilla, and 3 pieces segmented on 8 implants on the mandible as well. So everything looks very nice. Again, metal ceramic. I think we have very decent aesthetic result. We're gonna go into patient's mouth. We're gonna try everything. And all of these cases, we want to try and keep them screw retained, because when something fails, we're going to be able to go back and remove the restoration. So we utilize as well a protocol that was described by my partner Ricardo Mitrani, the CPR, in which we take into consideration the contingency, the priority, and the risk. So we need to know that everything we do is going to fail eventually. So once it fails, we need to be able to go back and help our patient. So we have here final pictures of our patient in which he's very happy, of our patient in which he's very happy, from a terminal dentition to an implant-supported reconstruction both in the maxilla and the mandible without going through removable prosthesis. So aesthetically, we have very decent results, and the patient, again, as I said, is very happy. So now we're gonna go into another class 2 case. This class 2 case was published at the QDT book in 2016. So if you want to go a little bit into detail, you can check it out there. So patient came in, again, older patient into university, and we have clearly a terminal dentition case. We have decay in most of his teeth, recurrent decay. Patient was previously restored and patched many times before, and at the end he decided that he wanted to get a treatment that he didn't need to go for failing restorations every week. So we know that this patient has terminal dentition case, so we decide to go through a similar protocol as I explained before. But in the mandible, we have very good bone. So on the mandible, we decided to do implant placement and immediate loading. But on the maxilla, the bone quality and the bone quantity was not as great. So we decided to place the implants and use a conventional osseointegration protocol and a tooth-supported provisional restorations, exactly the same as I explained in the previous cases. But on the mandible, we decided to go with immediate loading, where we feel very comfortable doing it in the mandible when we have good bone and good cross-arch stability. So once everything heals, I'm going to fast forward the case due to the time that we have for this webinar. So once we go forward with this case, the aesthetic workflow, again, we're going to start with the centrals. We're going to position them where they need to be, aesthetically where they need to be. Then we go through to the laterals, the canines, and then we go to the full arch. Once everything is set up, we try it in the patient's mouth, make sure that everything looks good, which we did in this case. And for this case, we're going to use a fiber reinforcement for the provisional restoration. This patient lived far from the university and he was taking some time off, so we were going to make him provisional restorations, but we wanted to make sure that they were long-lasting provisional restorations and we're not going to have problems with fracture. So this is part of a research that was published in the JPD recently. So if you want to look into the fiber force and how it relates to a conventional technique, please go ahead and take a look at the article. So once we have this temporary restoration, temporary prosthesis that have the fiber embedded inside, we're going to place them in the patient's mouth, and the patient is very comfortable. With this case, the patient allows us to be a little more creative with the position of the teeth. He didn't want the perfect white and unnatural smile, so we were able to give him something a little bit more natural, which he was very happy with. Then once we're done with that, the patient, again, as I said, went away for a while, then came back, and then we started with our lab work. This was done with Domenico Cascioni as well in Los Angeles, and then we're going to use a minimal cutback technique in which we want to try and keep as much of the restoration in zirconia. So we decided to go with a one-piece restoration for both the maxillary and the mandibular arch. So in this case, we went ahead with digital technology to do a copy mill technique, in which we had that worked with acrylic on the lab, and then we copy and we mill it with zirconia. So these are one-piece zirconia prosthesis on 6 implants in the maxilla and 5 implants on the mandible. But as you can see, we use this minimal layering concept. One of the disadvantages of layering on zirconia is that the bond to zirconia is not as good as it is with metal, or it wasn't as good. Nowadays we have better porcelain and better cooling techniques that make it much better. But again, if we can keep the strength of the zirconia with the aesthetics of the porcelain, we can have a balance there. We can get very nice results and very strong type of prosthesis. So again, all the incisal edges and the occlusal surfaces are in zirconia, and then we do minimal layering on the teeth and layering of zirconia on the pink area as well. So we're able again to get a very decent result for this case. Patient that had very difficult oral hygiene habits, and we're able to help him go through that. He again parafunction. He was very active parafunctionally, so that's why we decided to keep all the incisal edges on zirconia with minimal layering to avoid having chipping in the future. So this is a final result of the laboratory procedure. We go to the patient's mouth, we try it in, again make sure everything is passive, everything fits nicely, and aesthetically, as I said, the patient gave us a little bit of freedom. Aesthetically, as I said, the patient gave us a little bit of freedom to smile, which he was very happy with, and we're very happy with the smile as well. So, class 2 patients, two different scenarios that were discussed. One with a metal ceramic, the second one with a zirconia ceramic. First case was segmented in 3 pieces on 81 with a zirconia ceramic. First case 6 implants on the maxilla. So that moves the presentation to class 3. Now class 3, as I said before, is a patient that is going to be that was going to use an overdenture, but we have very limited vertical space, so that makes it difficult to use traditional overdenture techniques in which we use a bar. Nowadays we have low profile bars which are much better, but when we have limited vertical space, we sometimes use these type of telescopic techniques. You can also use locators. It's not our first choice. We really like to have something more comfortable and rigid for the patient. So we're going to show a class 3 case a little bit later down the presentation, and a class 4 just for documentation purposes is a bar. Here we have a spark erosion type of bar. You can use a low profile bar or a Marius bridge, as I said before, when you have limited space. So we're going to go into detail explaining the class 3 patient. Class 4, I think it's much more understandable around the world, so we're going to skip that due to time constraint. So this again was published, and here we have a patient that came in. This was treated with Dr. Adrian Polini at University of Louisville, and patient came in complaining about this was treated with Dr. Adrian Polini at University of Louisville. But most importantly, that the maxillary arch was, we can see, was an overdenture. We can see was an overdenture on 4 implants. So she was asking, can you do something like they did on the mandible for me on the maxilla? And we said, yeah, let's go ahead and start our data collection. So we started taking pictures. And first thing we do, as I explained multiple times before, is we try in the centrals, make sure that aesthetically they look good. And once we have the teeth in the right position, we're going to see how the lip and the ridge correlate to the position of the centrals. That the patient in the middle part of the upper lip had like a crease in that area. He had like a scar, so that complicated treatment a little bit. So when we first thing we tried is to go for a class 1 type of LTR patient in which we don't have any pink, because the ridge was very nice positionally from a vertical standpoint. But the patient had some horizontal resorption. So when we had a flangeless trying, that means without labial extension, the patient didn't like what happened in the upper lip. So we decided to put some wax on and show her how she would look if we used a flange on the restoration, and she liked it much more. So she said, I want to have something that is removable, that it's cleansable, and I want something with a flange because she felt more comfortable with the lip support, which a class 3 patient like this one, it's not very common, and that's why we're showing this case, because it's not very common to find them. But again, the denture into a radiographic guide to find them in the right patient. So we duplicate the denture into a radiographic guide. We decided to place 4 implants for this patient since we're going to be doing an overdenture. So we did the surgery for that patient. We wanted to gain as much vertical space as we could. And again, we have some anatomical limitations to how much we can gain. So we went as much as we could vertically. And then we did a biologically directed implant placement. That means that the implants don't have to be perfectly parallel, because we're going to use telescopes for this type of reconstruction, so we're going to be able to fix the angulation. So we start with our final setup with a center. We're going to go ahead and make our final trying. This is laboratory work by Arjan Deutsch, and he does magnificent work with removable prostheses. So once we have that, we're going to try it in the patient's mouth, and we're going to make sure that everything looks good. Here we had some minor changes on the aesthetics and the arrangement of the teeth, but in general, the patient was very happy. So once we have that, again, we decided to remake the mandibular overdenture on the previous implants, and we decided to go with zirconia telescopes on the maxillary arch. Using telescopes provides us with a good opportunity to correct any type of angulation problems, and gives us the advantage of having a removable restoration that is going to give that flange support and is going to feel very comfortable for the patient, but the advantages of being able to remove it and to clean it. So we have these galvano gold structures on top of the copings or on the telescopes, and a tertiary structure that everything is going to be picked up on the final restoration. So that gives us also the advantage of doing a palateless type of overdenture, in which it's going to be very comfortable for the patient without having the palate. So this is the final lab work, which is beautiful prostheses. We're going to try them in the patient's mouth, and as we can see, the patient is very happy with the restoration. We are giving her what she wants, which is a aesthetic restoration, which is removable, cleansable, and we're giving her the lip support that she wanted. So as you can see from this 3/4 picture, we're able to give her a very nice lip support by having that labial extension. So in the last 10 minutes of the presentations, I want to go over very briefly about new technologies. So from a summarizing standpoint, we went through the LTR classification, how to think, and we went through class 1, 2, 3, and 4. We went through class 1, 2, 3, and 4, showing different clinical scenarios with different amount of implants, different prosthetic designs, different materials, to try to clarify this concept. So what about new technologies? What about using digital technology for implant placement and prosthesis manufacturing? So we're able to publish this case in the JPD. This was case that I did with Dr. Jimmy Charette from U of L, and it was a patient that came in with a failing dentition. We decided to do a maxillary denture for him to start with, and an implant fixed detachable prosthesis on 5 implants and the mandibular arch. So here we worked with N-Sequence, which is a lab in the United States, in which we're doing a digital planning of the position of the implants, as well as a digitally planned prosthesis, which is going to be milled. So we work with the lab, and this is amazing. We have a stackable type of surgical guide and prosthesis as well. So as I said, we did a digitally planned maxillary denture with a implant supported fixed detachable in the mandible. So this is what we get from the lab after we go through all the analysis. We go through the surgical steps and we do the extractions. Then we have a bone foundation guide in which we're going to have perfectly stable, and we're going to know exactly how much bone we need to remove. We're going to place the implant, which are going to be fully guided. And then we're going to add the temporary cylinders and the pickup of the restorations. So this is very nice concept because it makes the surgery go a little bit faster and the pickup of the conversion a little bit faster as well. So this was the first case in which we decided to do the mandible only, and the maxilla was restored with a complete denture as an initial treatment planning. And we were very happy with the result. Everything went very smooth and the patient was very happy. So then he was restored with a final metal acrylic implant supported fixed detachable prosthesis in the mandible and a complete denture on the maxilla. So that showed us that digital technology can be used to have quicker treatments, but again, not in the sense of having everything done fast, because it takes a lot of time in planning and understanding how everything works, but in having the surgical procedure and the pickup procedure much more faster. So I'm going to show the last patient, in which is a maxillary class 2 patient, which we use digital technology as well. So this patient came to our clinic here in Mexico City complaining about mobility on the maxillary teeth and discomfort on the maxillary teeth. So we go through all the data collection pictures and we take some radiographs, and we see that the patient had an implant previously placed in the area of the premolar and a lot of bone loss on the area of the canines that were the abutment teeth for that fixed partial denture. So we have full series of radiographs, and for this case patient we decided to focus mostly on the maxilla for the sake of this presentation. So we go with digital treatment planning. We decide through the analysis of intraoral scanning and CBCT. So we use an intraoral scanning, and then we have a 3D information from the CBCT. We merge those together, and that way we're going to be able to position the prosthesis where it needs to be and the implants where they need to be. So here you can see the planning of the implant. We have very good bone thickness for this patient, and we decided to place 6 implants for these patients and go with a full arch zirconia maxillary prosthesis. So that this is the digital world. It allows us to go, as I said, a little bit faster during the surgical procedure, but it takes a lot of time on planning and a lot of hardware. This is using the N-Sequence lab. They print, 3D print and mill all of this for us. And once we get everything back, we're gonna start, as you can see here, we have the final prosthesis ready for pickup. And we go through the same steps that I showed before, but in a little bit more detail. We have a guided implant surgery in which we're gonna have the extractions done first. Then we're gonna position this bone foundation guide. Once we have this bone guide there, we're gonna remove the top part of it. It's gonna become a bone reduction guide, which is gonna show us exactly the amount of bone that needs to be removed based on our plan. Then we have our implant drilling guide, which is a fully guided system in which we played 6 Straumann BLT implants for this case. And once everything is where it needs to be, as I said, being a fully guided, we're going to place those implants where they need to be. And once we have the temporary abutments in place, they should emerge perfectly on the space that was left for the prototype provisional restoration, because everything was digitally planned. So once we go through that pickup process, we're gonna do the pickup. We're gonna polish everything. We're gonna contour everything very nicely, and once everything is contoured, we're gonna place it in the patient's mouth while we're suturing in surgery. Our team is working on contouring. This was done by Ricardo Mitrani, so he did beautiful contouring and polishing of the area. This is also work done by Humberto Ciprian and Diego Nambo from our team here in Mexico City. So it's very important that everything is very, very nicely polished. And once we have that, we're gonna go back to the patient, screw everything in, make sure that the occlusion is ready to go. And thinking that we did this from an intraoral scanning, a CBCT, and everything in the digital world, I think we're able to get a very, very decent result for a patient that comes in and in the same day he has this type of provisional restoration. So the digital world is something very interesting that we are working a lot in trying to create these digital workflows and understanding the limitations of that.
So for this case, just to wrap up the case, we have that, we're very happy with the restoration.
So we did a duplicate of that to make sure that everything was where it needs to be. And then once we have that provisional prototype, we're going to send it to our laboratory, and the laboratory is going to scan that and is going to start designing everything in the digital world. So we decided to use a prototype restoration to make sure that everything was perfect. Even though we were happy with the original prototype, we made some slight modifications to the proportions of the teeth. So this was done by Aníbal Garcia, which is a member of our team here as well, and is a CAD/CAM generated zirconia full arch restoration in which we go from the digital world to the prototype to the final ceramics. And as we can see that everything, once we have everything right, it becomes just a copy paste, just a duplicate of what we had before. So it makes it more easier to kind of finish these cases with less surprises and less problems with the patient restoration. So this is a final restoration, again, zirconia full arch class 2 from the LTR on 6 implants, and a patient that is very happy with the final results. And with 59 minutes and 30 seconds, I want to thank you all for your time and thank the organizers for the opportunity. Here is the webpage from our clinic and my email, personal email. If you have any questions, if you want to have any of the PDFs or anything that we described here during the presentation, please let us know, and we'll be more than happy to share and to continue sharing. I want to wish all of you the best of luck to continue to have that energy to learn and to become better every day and to be the best possible professional that we can be for our patients every day. So thank you very much and take care. Bye-bye.